level a couple of minutes. I would want at least 3 or 4 of you to switch on your videos so that I know that I can be talking to you, and you can unmute yourself whenever we want. Yeah, Sachi Jain, thank you. Anyone else? Hina, very good. Couple of more so that we can be a bit more interactive. Okay, I think we will start and then we'll see how it goes. So today I am assigned to take one case presentation followed by theory discussion on another topic. And I have discussed with Dr. Rajesh and Dr. Aditi to allow me to talk a little bit on how to approach theory paper writing and theory paper presentation, etc., rather than focusing only on the content of 2 different topics. So I have 2 hours to talk. I will try and divide it into 2 or 3 parts and we'll go about it. Since you all don't have a case ready with you, what we do at Nanavati Hospital, I'll try and replicate here, is that I'll be giving you chief complaints of the patient, and at least Sachi and Hina can ask me as if I was the informant. I will be the role player as far as this case is concerned, and give you relevant histories, whatever you ask me. And then we will discuss about what is missing in the history. If other people want more history, anyone can raise a hand or unmute and talk. Is that all right?
Yes, sir.
Fair enough. So there's a 10-year. I'm not sharing the screen right now because this way I can see more number of people on the screen, and I will share the screen a little later. So it's a 10-year-old boy who has been brought with history of fever for 10 to 11 days. And there is a neck swelling which has developed in last 4 to 5 days, noticed by the parents. So now you can start asking me history and I will feed you with whatever information I can. Yeah, Hina, go ahead.
Sorry, sir, will you repeat? Actually, got a call. So I didn't hear.
Can you all hear me clearly?
Yeah, now I can hear.
Okay. 10-year-old boy with history of fever for 10 to 11 days and neck swelling noticed by the parents for last 4 to 5 days.
So, sir, I would like to ask, how is the fever?
Sorry, I'm going to interrupt, Hina. Don't say I would like to ask. Imagine I'm the informant and you are asking me questions. So directly answer, no formalities needed on that.
Okay. So how was the fever? Like the grade of fever, and apart from that, like was it responsive?
So the father or the uncle would not know what you mean by grade of fever, right? So just ask me the questions. You can ask me in Hindi or English, whatever you are comfortable with. Just imagine I am the informant.
So how was the fever? Like mild, moderate, or severe?
The fever initially was mild, but last few days it is more. See, I'm not the pediatrician. No, I will only answer this way. So you need to ask more questions and do it quickly. We don't have much time on this.
Okay, and fever was continuous, or were you giving any medicine for the fever? Was it responsive to that medicine, or fever continued?
So first 2 or 3 days, fever used to come twice in a day, and we were measuring the temperature. It was around 100, 101, but the fever used to go away on its own before we could give medicine. But after 2 days, the fever was more, and we had to give paracetamol, or crocin was the medicine which was told to us, which we were giving 3 times a day, and still the fever used to come back after a few hours of giving paracetamol.
And how was the child like without fever?
Even now the fever is So in between initially first few days the child was reasonably well and was doing all the normal activity and everything. But since they have noticed the neck swelling has come in, he is complaining of pain, and he is now looking tired and lethargic, and he's generally not very active as he was in the first few days. See, what I'm saying is, don't wait to get a spot answers. There are no spot answers in any cases, right? So you go ahead, finish your all checklist, whatever history you want to ask, details. So there is randomly some questions are being put on the chat. So I would appreciate if one or two more people can come. This, you don't have to be added on the panel. Just switch on your videos. Yeah, anybody can ask me. Sashi, you want to ask something?
So has the swelling, the neck swelling, is the size the same or it has increased in last 4 to 5 days?
Size has increased in last 4 to 5 days.
And is there associated redness with the swelling over the neck, which you notice?
No redness is there, but some amount of pain is there. They are not sure whether the pain is inside the throat or whether the pain is on the site of the swelling.
Is there associated pain while swallowing also?
There is.
Okay.
So somebody asked me whether there is any swelling in the axilla, but we have not touched the axilla and patient has not complained of that. So we don't know. Even in the groin, we don't know. Parents have not complained about, I don't know. As an informant, we haven't noticed or whether there is or there is no other lymph nodes.
Sir, whether fever is associated with chills or rigors or cough and cold, or any particular time when fever rises to high degree?
So first 2 days there were no chills, but when the fever was very high and rapidly increasing, on day 3, 4, and 5 there were chills. Now again there are no chills, though the fever is still high. No particular time of the day, no particular association with any other events.
Okay, no headache, no bleeding from anywhere, no body ache, nothing.
No, nothing. At least those 3 things are not there. Yes.
Yeah.
No abdominal pain. Dr. Ashwini is asking any abdominal pain history. No abdominal pain history. No burning micturition. She has asked about history of cough, cold, running nose. Everybody has a little bit of cough and cold, which is on and off for him, but nothing major which required attention to the doctor. No pallor noticed by the parents. No bleeding, definitely. Yeah. Any scalp infection? We may be having some dandruff for last few months, but nothing more than that. Any bony pains? At least the child 10-year-old is not complained of any bony pains. And no joint swelling noticed. No limp, in case you want to ask that also. No change in the gait or locomotion.
Sir, any weight loss noticed or not gaining weight?
He's lost about 1 kg since he was seen 4 days or 5 days back. Because according to the parent, then maybe the child is not eating very well. He's a 10-year-old child, okay? Remember that. 1 kg weight loss. Ear examination findings. We are on history and I am the informant. I'm sure I have not looked at... I have not looked at the ears for sure. We are on history, doctors. So we said there is pain while swallowing. There is some background noise, so I'm going to ask to mute those people when there is background noise, okay? There is no history of difficulty in breathing or chest pain, but there is, as I told you earlier, there is pain while swallowing in last few days. No discharge from the eye or the ears. Actually, I should ask you every time you ask me a question why you're asking, but that will go on for a little longer. Mosquito bite history, yes, everyone has mosquito bites, correct. Yeah, very important question, Dr. Sashi, that Next swelling is bilateral or unilateral, right? So that's something you need to ask. So there, notice both side neck swelling. One is larger than the other. Since you asked me about abdominal pain, when asked pointed questions, they said there is some discomfort in the abdomen on the right side, but nothing more than that. No contact with TB. Come on, you have to take history. No, I'm the informant. How difficult that is, tell me. Either you should have the case ready, otherwise you have to ask me history. I'm ready to provide you with details. And if at any point in time you think you have asked me all the history, I'm fine with that as well. And then you can tell me the no aphthous ulcers, no stomatitis. Dr. Ina, you can unmute yourself when you have to speak because there is some background noise at your end. Any past history of treatment? No past history of treatment. No major treatment done anywhere. Travel history, no significant travel history. You want to ask left-sided history if you are done with all the major complaints? Somebody asked me history of jaundice. No history of jaundice. At least they have not noticed. No high-colored urine as well. Pain in abdomen, I said right-sided, some discomfort, but no severe pain associated, no vomiting, no loose motions. So since you are not asking, I'm going to provide you with history in order to save time. And Dr. Rajesh, you can pitch in anytime you want to see if you want to change the course of this discussion. So coming to the left-sided child has been taking adequate nutrition, has been developmentally normal, going to school, has had no major issues. Birth antenatal history has been all right, and he has been vaccinated as per the UPI schedule. Socio-economically, he is coming from a middle-class family. No other family history or other issues. He has one more younger sister who is 8 years old and has no major complaints. So if you have no more questions to ask, please summarize the history and give me a differential diagnosis. Anybody? You need to talk because otherwise it will become.
So, sir, 10-year-old boy with history of subacute onset of high-grade fever with cervical lymphadenopathy.
Bilateral cervical lymphadenopathy. Okay.
With constitutional symptoms in the form of reduced appetite. So it's less likely due to any viral cause. So here I would like to see further any bacterial or inflammatory, non-infectious inflammatory cause of these complaints.
Okay. Fair enough. Why do you say it is which bacterial infection you're thinking of?
So like tuberculosis.
Mm-hmm. Okay.
But child started with low-grade fever, having the constitutional symptoms in the form of decreased appetite, and there is a history of weight loss of 1 kg in around 4 to 5 days.
Okay. What else? Any other bacterial infection? Could it be tonsillitis?
No, the presentation won't take so long. So initially only I will have a high.
Fever started with fever, then throat pain, then lymph nodes.
The
I'm getting some answers
10 to
on which.
11 days.
Correct. Very good. So that would go a bit against the bacterial. Also, we started by saying that first few days the child had was relatively all right in between. Do you think any other any viruses that you can think of can still be a contender for this? So you're looking at fever for 10 days, correct? 10 to 12 days. So you should think on consider that should be the major thing. And on top of that, you should add something else. So in virus, they have written on chat box EBV. Can EBV be responsible? Can EBV be responsible for this? What is the presentation of EBV usually?
High grade fever with like generalized lymphadenopathy, but they'll start with the oral.
Cervical, you mean?
Yeah.
Okay, so EBV still remains a contender because it's like a PU or differential, but here you have fever, throat pain, difficulty in swallowing, and bilateral cervical lymph node, bilateral neck swelling. So that still remains a possibility. Can this be a retropharyngeal abscess or any other bacterial localized problem with lymph nodes? Because we haven't certainly said this is lymph node. We have said lymph nodes, but we haven't ruled out localized infection with lymph nodes, correct? So what are the points against this?
Retropharyngeal abscess both present as a neck swelling. The child will have a high grade fever and a difficulty in swallowing and toxic because of the underlying bacteria. Child will be sick, but there won't be any neck swelling.
Okay, so they can sometimes be, but more importantly, they will have neck spasm, right? And neck pain and neck spasm, or what we call pseudo neck stiffness. Okay, and bilateral is also less likely. They have written hot potato voice, etc., etc. There was some discussion for further between non-infective causes on the chat box. So they have written leukemia. So what are your thoughts about whether it can be leukemia or lymphoma, whatever you want to put it? Is it possible?
So leukemia is less likely because the usual presentation for leukemia is child will have high grade fever, irritability because of the underlying bone tenderness and reduced appetite. One of the possibility can be lymphoma, but less likely of leukemia.
So what is one feature which goes against lymphoma here? We can't hear you, Sachi. Can't hear you. Anyone else? Yeah, so lymphoma usually is a what do we have here? Can we just go through the positive points here? We have fever for 10 to 12 days. There is pain while swallowing. There is throat pain, and there is swelling in the neck. So lymphoma generally does not come with pain while swallowing and does not have any internal pain or swallowing, right? They have only lymph node swelling and not within the throat. So this points to something which is in the throat or somewhere locally. Along with that, there is cervical lymph nodes. Okay. Then somebody has put enteric fever or typhoid fever. Enteric and typhoid generally doesn't come with bilateral cervical lymph node as a presentation. So we will not think about that to start with. Also, Bartonella or cat scratch disease has been put, which is a very good thought for any localized lymphadenopathy, especially if it is axillary or inguinal, but very unlikely for a cervical lymph alone. Okay. Syphilis in a 10-year-old, extremely rare. We will not get into that. Okay. And rickettsia doesn't seem to be likely, correct? So what are we left with now? We are left with tuberculosis, we are left with EBV, and we are left with non-infective, less likely, but non-infective conditions like lymphoma. Okay. So in the exam, you will be asked if I am told that not by the board, but by the students that probably next time it's going to be a physical exam and next time onwards and not a virtual exam. So you will be presenting a case and it won't happen like this. So it's a sincere request that now onwards, whenever you get opportunity, please try and present a case rather than trying to do virtually. Thankfully, the days for virtual presentation seems to be getting over. Okay, so these we have taken care. So assuming this, what are the positive findings that you expect on general examination? Yeah, anybody can answer.
So in
Or
general
rather, I would put it
examination,
other
like,
way around. Should I say, what would you look out for?
so nutritional status of child. Then we'll see, is there any pallor, and
Do you expect pallor?
and then we will be, not for this much duration of illness, unless like child is having other associated factors for this.
Okay.
And then I'd like to do the local examination for the lymph nodes, like
Excellent. So,
what is the size and whether it's
so what all things do you examine? Let's spend some time on this. How do you examine a lymph node and what are the features that you will describe?
size, consistency, tender or non-tender,
Very good.
matted or non-matted.
Okay. Mobile or fixed.
Yeah, mobile.
Okay. And skin over the lymph node. Right. So skin over the lymph node means whether it is fixed, whether it has any scar, sinuses, discharge, redness, etc. Correct? Okay. Fine. And you will also obviously say how many are there number wise and whether it is on one side or on multiple sides. Yeah. So Dr. Mona Lisa Pradhan has written size, consistency, matted, mobile, unilateral, and numbers. Right? Okay, good. So now I want you to tell me on the growth chart, what do you think this child would be? Because as you know, if you attend science clinics, we'll always ask an anthropometric diagnosis or anthropometric assessment. What do you think this child's height, assuming that the parents are of average Indian height and weight, what will be the height and weight of this child? And why do you say so?
With the past history not significant, and duration of illness is only 10 to 12 days, so we expect his height should be normal.
What is normal?
Between 0 to -2 standard deviation.
On a figure, 10-year-old boy.
Okay, 10 years, 50, 5.
Sachi, can I hear? Can you say? Okay, somebody said around 130. So anything from 130 to 135 will be acceptable. What is the weight that you want for a 10-year-old well-grown boy? So at 10 years, it's safe to say 130 and 35. Okay. but there could be a variation, assuming that the parents are normal.
Weight around 30 kg, around 30 to 30.
So what other things can be asked? What other things you want to examine on general examination, considering the history that you have?
Other sites for lymph nodes,
Okay. Which other sites?
like axillary or groin region, inguinal
Yes.
lymphadenopathy,
Yes.
and inflammatory.
What else? Other sites and what else? Anybody else wants to switch on their video, please feel free to do so. So apart from different sites for lymph nodes, would you examine supraclavicular and epitrochlear as well?
Yes, sir. Yes, sir.
We'll discuss that a little later. Any other findings? Which other system you want to examine in this child?
For abdo, for any organomegaly, like fever, spleen.
Okay. What kind of liver abnormality do you expect in this child?
If you're considering like it's a EBV infection, so then we can get the hepatosplenomegaly in this child.
What kind of liver will be? Will it be tender, non-tender, soft form, hard?
Soft liver, non-tender.
Or mildly tender, can be mildly tender, because in any acute enlargement of liver can stretch the capsule and one can have little bit of, can be mildly tender. And on history, if you remember, we said discomfort. So on the right side of the abdomen. So probably we can say maybe that. And if it's a firm liver, then you think in terms of non-infective causes also. Okay. Then you should know whenever you have a case like this, how to examine the neck. So I don't know how to do that today on virtual platform, but some point in time, I'm sure Dr. Rajesh and Dr. Aditi will arrange for clinical examination classes where you must know how to examine the thyroid and how to examine the lymph nodes. In lymph nodes also, which ones to examine from behind, which ones to examine from front. When you examine the axillary lymph nodes, you have to make sure that you support the elbow in order to relax the fascia so that you can get the proper feel. Also, you must know that axillary cavity is in a pyramidal shape, and hence you should be able to palpate all the walls before you can say there is no axillary lymph nodes. So we said if you noticed an abdominal lump, how will your differential diagnosis change? You said just now, right? So if you see liver, then you will think of no, abdominal lump does not jump. Don't jump for metastasis. We are still talking about liver and spleen and not anything else. Yeah, could be TB or malignancy. Why do you say tuberculosis? In fact, I would think other way around. If I get liver and spleen, it will go against tuberculosis, because liver and spleen enlargement in tuberculosis happens from miliary tuberculosis, which is a condition of poor immunity, and lymph node enlargement is more of a good immunity or an allergic reaction kind of a thing. So it's unlikely. Which particular type of tuberculosis you should look for when you get a cervical lymph node? So you should look for apart from Mycobacterium tuberculosis, should look for NTM as well. Okay. Non-tubercle Mycobacterium as well. Okay. So now we have on examination, anything else you want to examine? I thought one very major area we are not still looking at. We haven't done ear, nose, throat examination, right? So we should do the throat examination. Am I right? Because anyway, we should do for everybody, but in this child, it's even more important. So what do you expect? Suppose I say that when you saw the throat, child had a very large tonsils and there was exudative membrane on bilateral tonsils. There was snoring, some amount of drooling, and there was halitosis also. Snoring or noisy breathing. Child was awake, so snoring is not the correct word. Okay, somebody said retropharyngeal abscess. Okay. So remember, in retropharyngeal abscess, there is no white patch or white exudative tonsillitis.
Most likely suggest of acute bacterial tonsillitis. It's having exudates which are drooling.
So exudate is not the right word. I'm saying whitish material on the tonsils. This is what happens because I'm describing something which I have seen. So diphtheria, the child would be very sick, and diphtheria generally doesn't come with severe bilateral lymphadenopathy. It's more likely in EBV that you see a white patch or white membrane on the tonsils on both sides. Of course, in diphtheria also you see, but the child will be more sick, and diphtheria generally does not have hepatomegaly, whereas this one has hepatomegaly. Okay, fine, fair enough. So remember that one could have even neck difficulty in swallowing, and because of very large tonsils, there can be some drooling and halitosis as well. Okay. So what investigations would you like to do with these findings? You have a liver which is 4 centimeter non-tender. Sorry, I'll start from the beginning. Well-grown child, bilateral cervical lymph nodes, which are soft, some are firm, more like, and they are not tender, non-matted. Size is about 2 centimeters, 3 or 4 on one side and about 4 or more on the other side. And the throat is showing bilateral tonsillar enlargement with a white membrane, and liver which is about 4 centimeters. Spleen is just palpable, only in left lateral, only when you turn the patient on one side and try to examine, you can get a little bit of spleen. There's no bony tenderness, no petechiae purpurae, no other abnormalities, no other lymph nodes anywhere else in the body.
EBV serology, because
You want to do a CBC first? I agree with you that you may have EBV as in your mind, but do you want to do CBC? So can somebody tell me what is the role of CBC in cervical lymphadenopathy? Not only in this child, but in general, if you see lymph node on the cervical lymph nodes, what is the role? How do you go about it? How will CBC help?
Sir, a high total WBC count may point towards acute bacterial lymphadenitis.
Okay.
Neutrophilic predominance may be there in differentials.
Okay.
Then, sir, if the cervical lymphadenopathy is of a chronic duration and like when we are suspecting a non-infective cause like malignancy, there may be associated anemia. Pancytopenia may also be there in malignancy.
So that is what you should say, right? If there is a pancytopenia, then you're thinking in terms of a malignant disorder.
Malignancy. Sir, EBV can also present transiently with pancytopenia on CBC.
So EBV classically presents with increased in the WBC with lymphocytosis, but with low platelets and borderline low hemoglobin. Okay, EBV doesn't present typically with, but again, you can argue by saying that low hemoglobin and these two cell lines are depleted, so pancytopenia. But the general impression of pancytopenia we say when you have WBC and platelets going down, right? What else?
Sir, a tuberculous cervical lymphadenopathy may even have a normal CBC.
Agreed.
Or mildly raised total counts with lymphocytosis may be there.
Correct. Anything else? How will you investigate this child? After CBC, what else you want to do? Anything else you want to do other than CBC?
The ultrasound of the neck.
Very good. What do you expect and what are you looking for?
So, like, we will see which group of lymph nodes are enlarged, and like if there is conglomeration of the lymph nodes or it's a single enlarged lymph node.
Okay.
And if it is a necrotic or a non-necrotic lymph node.
Excellent. Yeah. Fine. So according to me, the only reason for doing ultrasound for the lymph node is to see if it's necrotic or non-necrotic. It really doesn't matter to you how many, what is the number and what is the size, etc. Because eventually, even if it is 2 centimeters clinically and 2.5 on ultrasound, though there are guidelines which change more than 2 centimeters, your approach is not going to change. Being non-invasive, easily available, accessible, you can do it is a different story. But other than a necrosis or liquefaction, if you are thinking in terms of acute bacterial lymphadenitis, there is nothing else that will help you. What I'm trying to say is whether it is non-necrotic and tuberculosis or whether it is malignancy or Kikuchi, your sonography is not going to help you. I'm getting few responses on the net and I want you all to respond. Someone has written Mantoux test. So I'll argue for and against Mantoux test in this patient. You can say I don't want to do it and tell me why you don't want to do it. Doesn't matter. Okay, so if no one is answering. Yeah, Hina?
Yes, sir, because on general examination and systemic examination, the points do not favor towards the tuberculosis. So
I will ask you a question in a different way. If Mantoux is positive, what do you think? If Mantoux is negative, what do you think?
Mantoux is positive, that means the child had been infected at some point of time.
So will you make a diagnosis of tuberculosis on that basis?
So that cannot be the diagnosis of tuberculosis at this point of time.
Correct. So if it is positive, nothing changes. If negative, nothing changes. So why do it? That means for a 10-year-old, Mantoux test in this child is definitely not indicated. Okay. Somebody has written FNAC. I want comments on FNAC. What are the advantages and limitations of FNAC? And against FNAC, what is it? You have three options, either to observe or to do FNAC or to do biopsy. Correct? Yeah, I agree, not required in this case at this point in time, probably. We will see, we'll talk about indications, etc. So FNAC basically is an easy to do investigation, relatively non-traumatic, does not leave a scar. So that sometimes becomes a decision maker for many people, especially in open areas like the cervical region, because scars have their own stigma. But FNAC has a low yield, has a very high chance of missing the diagnosis, and you can't get histopathology on that. You can get gene expert, or you can get at the most some cultures and some cytology, but you can't get anything else on that. So I would not do FNAC on a cervical lymph node, which is accessible to me. I would always prefer to do an open excision biopsy. Okay, so we are at 3:45 and I don't want to give more than 10 minutes for this because that leaves me only an hour to discuss the theory part. So I'm going to just go through some questions and I'm going to ask you to answer quickly. If you don't answer, I will answer them. Okay. So investigation we have discussed. What is the role of imaging? We discussed on sonography. Any special test you want to talk about? So suppose
Sir,
HB
this
is 11 with an MCV of 75, platelet is 1,05,000, and the WBC is 15,000 with 70% lymphocytes, few atypical cells, but no blast cells seen on peripheral smear.
EBV serology.
ESR is 40, CRP is borderline elevated, in case you did. So what does EBV serology mean? See, when you answer in the exam, please don't answer EBV serology because the examiner will have to ask
IgM,
you again.
EBV, IgM.
Okay, how many are for EBV IgM? So what is EBV IgM? Do you write EBV IgM or what do you write? What specific, what do you ask for?
Sir, EBNA we can ask for.
Okay, or
PCR,
we can ask for EBV PCR,
PCR.
or we can ask for IgM VCA EBV, right? Viral cuspid antigen. Okay, fine. Any other test you want to do? You want to do a bone marrow?
Not at this point.
Not at this point. Okay, so we'll discuss this also. So what other points are discussed? Now, this is a bit more general, not necessarily focused on this case. So if you have cervical, if you have lymphadenopathy, what are the questions that can be asked? So we will run through this quickly, okay? What is generalized lymphadenopathy? You can answer one by one. Sachi, Hina, you can answer to each, whatever.
So more than 2 non-contiguous site involvement.
More than one non-contiguous sites, correct. Abnormal size. When you call it abnormal, a lymph node in different areas.
1 centimeter for cervical, more than 1 centimeter for cervical and axillary, and more than 1.5 or 2 centimeters for inguinal lymph node.
And any size for epitrochlear and supraclavicular. What are the worrisome features in a child with lymph node, lymphadenopathy? Tell us some features which would be like red flags, correct? In any condition, you must have some red flags. So we can have features of the lymph node and other features in the child. So for example, I would say hard lymph node, matted lymph nodes.
With skin changes, overlying
skin changes, okay. Large lymph nodes. So which size lymph nodes you would go for? Because see, if you have worrisome features, you will go for aggressive investigations, correct? So large size necrosis, discharging sinuses, pallor, petechiae, etc. So you should go systematically whenever you are writing an answer or where you are giving answer in the exam. So features of lymph nodes which can be unusual are if they are 4 centimeters or more, if there are any systemic signs like very high fever, weight loss, and all the other things that we mentioned, pallor, petechiae, etc. Or we said if they are matted, if they are hard, if there is a discharging sinus. Okay, and the site we mentioned, if it is a supraclavicular or an epitrochlear, correct? Fine. I don't think we have time for approach to cervical lymph node lymphadenopathy, but I'll give you a rough idea about how to think about it. So whenever there is a lymph node, you say what, first you always rule out if there are any worrisome features or red flags, like any condition. After that, you see whether there is any obvious focus of infection which is leading to a cervical lymph node. Now, if it is a cervical lymph node, you want to look at scalp, you want to look at ear infections, you want to look at the throat, you want to look at dental cavity, and so on. If it is axillary lymph nodes, you should look at any pyogenic focus, any injury or any thing on that particular limb, or you have to think about cat scratch disease, which is one of the conditions which can lead to localized axillary lymphadenopathy. So you need to rule that out. If there is an epitrochlear lymph node, we discussed a couple of weeks back in the science clinic also, you should think about One is EBV. Second, even in leukemia, one can have epitrochlear lymph nodes. In olden days, Dr. Amdekar sir said that in syphilis also they used to see epitrochlear lymph nodes. And of course, any localized focus of injury or cat scratch disease can also give rise to epitrochlear lymph node. The same differential goes more or less for the inguinal lymph nodes, but you have to remember to add sexually transmitted diseases and of course sexual abuse when you look at any inguinal lymph nodes present in a child. Abdominal lymph nodes and thoracic lymph nodes are a separate discussion. We'll not get into that. Right now, we're looking at a peripheral lymphadenopathy. Differential diagnosis of neck swelling. One more thing, when you talk about abnormal size or any neonate with, I'm coming to that a little later if there is time. Otherwise, I will have to just go through it quickly. Okay. Etiology of cervical lymph nodes you can read up, and clinical features to differentiate different types of lymph nodes. So you should be able to have some description, like if it is Kawasaki, it's usually unilateral, looks like a lump, but lump of lymph node, but on ultrasound, you will see like bunch of great small lymph nodes which are merged together. If it is lymphoma, then you will see large lymph nodes which are non-tender. If it is EBV, then you can feel rubbery lymph node, which of course in lymphoma also the same description is applied. Okay, if it is a metastasis, it's more likely to be formed to hard lymph node. If it is matted lymph node, what is matted? Matted means multiple lymph nodes together where their capsules have no differentiating area in between. They are stuck together or they are fixed with each other. If there is no free skin above, then it could be either a simple bacterial infection or it could be a metastasis again. And of course, matted lymph nodes, and then they can, with the bacterial lymph node, they will be red, tender, redness, tenderness with surrounding swelling and with or without fluctuation. So that will tell you whether this should be drained or should be treated only with antibiotics. Okay, we have approached, we have taken care of this. So this, I don't think we have enough time, but if you have a very young infant or neonate in whom you palpate a lymph node, remember, apart from the standard posterior auricular and occipital lymph node, any other lymph node in a newborn more than 1 centimeter is considered abnormal. The sites I already mentioned which are normal. BCG lymph node and BCG lymphadenitis and its management is a separate discussion. I think you should know how to palpate when it is abnormal, how it may look on X-ray, and how to treat one. Discussion about biopsy. So what are the indications? Can anybody tell me what are the indications of doing a biopsy? So I was talking about approach to cervical lymph node. So there, basically any lymph node, first thing you see is rule out red flag signs and worrisome features. Then you see whether the size is more than 2 centimeters or less than 2 centimeters. If it is less than 2 centimeters and you have no focus of infection and no systemic abnormalities, you are all right to wait and watch this child for 2 to 3 weeks and see the progress of the patient. If any time there is a localized infection or you know the cause because of any other reason, then obviously you will treat that condition. If it is more than 2 centimeters and you don't find any cause, you need to do a simple CBC, CRP or CBC ESR with or without LDH depending upon what is the general presentation. And if required, an ultrasound and further investigation to rule out tuberculosis in our country. If the size is more than 4, I'm talking about everywhere where there are no red flags, the size is more than 4 centimeters, if it is a supraclavicular lymph node or a group of lymph node with multiple lymph nodes with even more than 3 centimeters, I would advise to do an early biopsy. Okay, so these are the indications for doing an early biopsy. If any lymph node while under observation increases in size to more than 2 centimeters, we should do an ultrasound, do an early biopsy. What are the different biopsy routes? So obviously, so the second question is which, if you have multiple lymph nodes, which one will you biopsy? Ina?
The accessible one and the one which is larger in size.
Excellent. So just because a larger lymph node may give a larger scar doesn't mean you go for the smaller lymph node to avoid the scar. Go to the most accessible site and also go to the most abnormal site. So you have cervical and supraclavicular lymph nodes, and better to go for a supraclavicular lymph node. Okay. And the larger or the more any lymph node which appears to be most abnormal, you should go that. Time and indication we have decided. What are the tests, different tests that you can perform on a biopsy?
Histopathology, CDMA.
You send a biopsy for histopathology. Depending on the case, things will be different, but you will also send for cultures and inform them to send different cultures, especially for even for fungus and other serology. If you're thinking in terms of malignancy, then various immunohistochemistry and other markers can be performed on the biopsy. So you need to inform, best to discuss with your histopathologist and lab about what they want and how they want the samples to be sent. Okay, of course, not to forget AFB and gene expert, as Dr. Rekha has mentioned on the chat, right? So what we'll do is I'll just tell you quickly what are you expected in a case presentation, and Ambika sir is here, and so please feel free to interject and correct me whenever you want. So you start by presenting complaints, go through your ODP, make sure that you present relevant history and relevant negative history. Whenever you give any negative history, make sure that you have the diagnosis more or less attached with it. So it's like saying no bone pain, night sweats to rule out malignancy, something like that, you know. Specific questions regarding important differentiating points should be highlighted. History, more details to be provided while not missing out on the left-sided history. Always summarize and give your history. Whenever you give your clinical diagnosis, make sure that you cover the anatomy, pathology, etiology, and affection. What I mean by affection is, how is this affecting the child's day-to-day life or condition? Means what is the severity, what are the limitations that it is causing the child? Because many times you will not be doing justice to the child if you don't address their problems in day-to-day life. The other thing is what is looked for is what all things did you examine? How accurate was the examination? You will be asked even to demonstrate certain findings or certain signs or method of examination will be carefully observed. You should run through your mind about red flags and potential complications, like how we said for this condition. And if you have time before you present your case, make sure you prepare a small summary, which the examiner will always ask you, your clinical diagnosis and or a list of differential diagnosis. And every time you present a clinical diagnosis, you need to cover these 4 points which I said, but you also must make it customized to this particular patient. So if you have a child with thalassemia, hardly ever any points will be given to you. A 10-year-old you will be getting points for saying this is thalassemia major. I mean, that anybody will be able to tell you. So there you will be talking more about what is the growth, how is the iron load, what are the other complications, etc., which you will mention in your diagnosis. Okay. The next discussion usually is how to investigate and why to investigate. So any investigation you ask for, you must know what the result you are going to expect and how will it change your management. Okay. whether it is for differential diagnosis, whether it is a confirmatory test, or whether it is to grade your severity, or whether this test is meant for choosing the drug like culture or biomarkers to or markers for ALL, suppose you're doing, to choose your protocols and therapies, or whether it is simply to monitor the prognosis and further course of treatment, or it is whether the child has been compliant or not. So for example, for celiac, if you are going to monitor a regular anti-TTG, you know whether the child is on gluten-free diet or not. Sometimes they will, some investigations reports will be discussed, treatment options will be discussed, and obviously all these points about not in this child, but in any other case, these are the other things which come up in discussion. Okay, so I think we are 1 hour into our talk, and we will stop here and we'll go on to the theory. You have any questions, queries, please feel free to ask. If possible, I will try and prepare a post-assessment questionnaire and share it with Dr. Rajesh or Dr. Aditi, and we'll put it, and the password we will be providing at that time. But as of now, this is the password, pediatric teaching file, so PTF, and today's date is 2302. Any questions, or should we go to the theory? Okay, since there is no response, I suppose we can go to the theory. I'll just share the screen and we'll start with that. Okay, so what I'm going to do here is, it's going to be a one part of this. I will try to cover how one should write the theory exam. And second part, I will try to quickly cover exanthematous fever, so or fever with rash as it is called. I don't think we'll have enough time to address persistent pneumonia today. That's what we discussed. So we'll focus more on how to write the theory paper, and then we will show you about this. Okay, can you see the slides?
Yes.
You can, right? Okay, good. Let me minimize this a little bit because there's not much happening now. Okay, so approach to fever with rash. What we are going to do is approach to approach. So what I'm going to do today is what should be your approach to pass the exams, and preferably in the very next attempt that you appear, whether it is theory for the first time or second time, or maybe even more than that. So how to do the preparation for theory, how to write the paper, how to address each questions, and what should be the content of the question. Obviously, I'm only going to give you some idea about this. Everything together cannot be addressed. So approach to paper writing. And before I start, I need to say, why not pass? This is the question which was raised by my teacher, one of my teachers, I should say, Dr. N.C. Joshi sir, and many of the slides are to his credit because he had started a theory teaching program at Nanavati in 2010, in which I was also fortunate to be a part of it. So some content of this PPT is from Joshi sir, and of course, many more of his inputs are there in my life. So thank you, Joshi sir, and I'll go ahead now. How do you write a theory paper? The most important challenge is to understand the question. Now, this sounds simple, but that is the crux of the problem. Always give 2 minutes and prepare a skeleton answer, in the sense you decide what points you're going to put. You can actually write down these points on a page which is marked as rough page, or on the side of if your sheet, you can just draw one line and write rough and put your points. What will happen is, once you get into the flow of writing, and imagine you're writing on that topic for 15 minutes or more, you are likely to forget some important points that you already know. And believe me, these 2.2 minutes are very well invested. It will happen that some questions you have prepared very well and you will be inclined to use more time on that. But remember that you can only get certain marks out of a given question. And usually there are 10 questions. Nowadays you get 2 short notes per question. So you can divide everything by 2. In 180 minutes, you have to answer 10 questions, and that becomes 180 minutes. And my maths is not bad. I have purposely put 17 minutes per question, and I'll explain why. Out of these 17 minutes, give 2 minutes to think about your question and write for 15 minutes. Your 2 minutes will be extremely useful. Now, if you say 17 minutes into 10, that leaves you 10 minutes to go through the paper. Don't go through the paper in the beginning. There is no point. You can't change it. So there is no time to be spent on going through the question paper. It can only give you grief or a false sense of euphoria. Finish your paper and keep 10 minutes at the end. Go through the answers. And again here, you will know that some points you have now thought about, which you have not written, or you will have time to underline or box or mark some important points. While writing answers, make life easy for the person who is correcting, because he or she will always feel happy, and once you are feeling happy, you will always give more marks. This is just a human nature and nothing you can do about it. So write in bullet forms, write in indents. All of us prepare PowerPoints, so you know that you can write the topic, then subheading, then subheading. And when you write, don't write all of them in straight line. Write first, then leave a little bit of line, and then write in the second area, and then in the third area. Okay. Try to underline important points and subheadings if you have time. You must include certain keywords, and when you include keywords, make sure that you underline those keywords. Whenever possible, line diagrams should be drawn. Flowchart and algorithms, even if are not asked as a compulsion, should be included. If you have references like this is taken from this particular point is from this book or that, don't keep writing Nelson, Cloete, and Harrison in each and every answer. That doesn't help. What I mean is, suppose it's a WHO guideline or a European guideline or Indian Academy or Government of India, feel free to write that. That also gives you the authority to mention what you are writing, plus also tells the examiner that you have read them. Always give examples. So if you write any particular point, try to write answers, conditions, and situations which fit into them. Avoid full sentences, because it takes time to write and it makes your examiner having to read the whole thing. In the process, they may miss what is important. So if you have written bullets, it will be much easier for them to correct. There is no point in hiding somebody's ignorance by writing lots and lots of material. Doesn't work like that. No one weighs your answer sheet and gives you marks. Okay. Now you are asked to ask 20 questions actually instead of 10. And so you can imagine each question is only 5 marks. So obviously you are not going to be given marks for writing more information. Don't worry if your answer is just of 1 page. If their answer is so specific, that's all you need to write. Don't write unasked information. So if they asked you clinical features, there is no point in writing investigation and management just because you know it. You will unfortunately won't get any extra points. Please don't write outdated or controversial treatments. Both of them are looked down upon and will waste time in writing it. Do not use red color to underline, okay? Because many examiners will be using red pen to correct their papers, and it is generally discouraged to use red color to underline. You can use, if you're writing with a black pen, you can use blue pen, you can black or any other colors. What is optional or preferred writing? So Obviously, better if you have good handwriting, excellent. If you don't have good handwriting, at least have legible handwriting. Try and avoid doing too much of overwriting. If you cancel something, make 1 or 2 strokes and write something next to it or above it. Try to answer in the same order of questions, but many times you don't know, you can leave a page and then write the next one. Always start a new question or even a sub question and make sure that you number it correctly and start on a fresh page. That makes the examiner also easy and for you also to add few points if you want to add subsequently. How do we approach a question? So let's understand what are the different types of questions asked. Now, almost last few turns, at least that I have gone through the input which has been given to me by the students, they come in short note forms. Means there are question number 1 will have A and B and there will be 2 sub questions. And most of the time they'll say write short notes on. What do you mean by short notes? So short notes are short answer questions, and what is expected is to understand what is your ability to condense the material and present in an organized and orderly fashion. It should be complete, but your thought process should be reflected in that, apart from obviously the appropriate and complete content. When you read the question, make sure that you carefully pay attention to if there is any age specification. For example, if it says 14-year-old child with fever and rash, then your differential diagnosis will be different compared to a 1-year-old infant with fever with rash. Okay. Now, if the condition also you should remember, so if somebody writes, give management of refractory shock, then you should start from the point, you can define what is refractory shock and start your management from that point onwards. And there is no need to start from the time of giving diagnosis of shock from that point. In a given situation, also you should remember and specific guidelines if they have written, write the WHO guidelines as per management, as per this, or write as per NTEP tuberculosis guidelines, etc. Always read the presentation carefully because there will be points put over there which will help you give specific answers and avoid stuff which is not asked for. Let's look at some other questions. There are some questions where they say draw a diagram. For example, urea cycle. You don't have to write anything, but you must number or you must label the diagram. So you must always, whenever you draw the diagram, you must put different parts and put the label to it. If it is explain the embryology and neural tube development, obviously you will draw different stages of neural tube development, but it is always a good idea to write the fetal age or gestational age at which these things occur. Because though it is not mentioned, it is understood that the diagram for embryology is not complete without mentioning the gestational age. There were a few questions saying, explain in tabular form or tabulate clinical features of JIA. Now, if you are asked to tabulate, you cannot write sentences. You will have to draw a table and you will have to have, for example, different types of JIA on the x-axis and different clinical features on the vertical axis. If there is an algorithm asked, for example, management of status epilepticus, you can write 1 or 2 lines on what status epilepticus means if it makes you feel good, but definition has not been asked and you may not write what is status epilepticus. But it is safe to just say status epilepticus is equal to so and so, and then go on to write the management. When you write management, if there is branching or options of using drug A, B, and C, you can mention and you should mention. Generally, in emergency management, it is good to write the dosages as well. and you must write in algorithm, obviously, if this happens, then you will do this, and if this does not respond, then you will do it this way. Okay. The final one is that I could think about was provide a flow chart. So that's when I say what is the difference between flow chart and an algorithm, is algorithm usually are meant for these different managements, and flow charts are for PALs, NALs, etc., which are fixed, and they will have some narration or actionable material. So if you write for PALs, not only you will write the flow chart, but you will also write about 5H and what other events are mentioned on that sheet. If you are asked to define, you simply have to make a statement that explains the meaning of what it is. And every one of us knows definition. According to me, this is so specific that it's always very difficult to remember and write. Etiology covers theory of causes as a disease process. Whereas enumerate means you don't have to discuss anything, you have to just enumerate. But when you enumerate, it's not necessary, it's not a great idea to enumerate alphabetically. You can say a few common conditions are that you can write 1, 2, 3, 4, 5 if you want. Then you need to have some kind of skeleton or some kind of concept, whether it is, I will come to it, whether it is age-wise, whether it is etiology-wise, or whether it is system-wise. When you're writing about pathogenesis, you write about genesis of a disease process. So what happened at pathology level in order to this symptom, this disease converting into a symptom or a sign. And pathophysiology is you describe the physiology and then you write disturbance in that physiology, which means pathophysiology, right? And same way, etiopathology means cause and development of the disease or abnormal condition. So here you're focusing more on different causes leading to this pathology, whereas in the previous one, you are talking more about disturbed physiology, which is leading to this condition. Clinical manifestation, we all are very good at writing, so should include symptoms as well as signs. And again, there should be some, I mean, you don't need to write investigations and other things. Okay, treatment and management are fairly specific. Some people would say management includes treatment, prognosis, treatment, follow-up, prognosis, and quality of life, etc. Whereas treatment only includes specific treatment, acute as well as follow-up. This I've already spoken. When a specific question is asked about refractory, whether it's a refractory shock or whether it is refractory anemia, that means that the child has been offered the regular course of treatment but has not responded to that. And when you say intractable, means it's one step further from refractory. So it will mean that all the conventional treatment has failed. So whenever this particular point is asked in the exam, you don't really need to start from the first stage of management. You can start from wherever things have not gone well. Differential diagnosis is an attempt to distinguish between similar manifestations. Sounds simple, but again, there is no point in just writing various conditions. You can write differential diagnosis, but difference between enumerating the causes and differential diagnosis would be that with differential diagnosis, you will be describing points in favor and points against. Okay. And lastly, we come to this approach, which is the today's case scenario. And in this, I normally like to, there are various ways to write approach answer. And one of the common ways of writing an answer is to treat it like an exam case or like a clinical case. So you go through history, examination, findings, and then each one you keep giving differential diagnosis. Finally, you can have again here an algorithm or a hierarchy chart where you can come to a diagnosis. So we'll give you examples, not for fever with rash, but just for fever. Okay. So if a fever definition is asked, you say fever means elevated body temperature above normal range. Now that means you can discuss about what do you mean by the range? Is the range different for different time of the day? And what are the factors which affect the range? For pathogenesis, it would mean elevation of hypothalamic physiological set point for body temperature, which may lead to either increase in heat production or can cause decrease in heat dissipation. Both of them can give rise to elevation of temperature known as fever. In pathophysiology, you can have disturbed function leading to a symptom. And pathological level and hypothermia means pathological, physiological means just increase in temperature. They're just the examples. And moreover, when you are asked a question, there will be many more things to write. This we have already discussed. So let's look at this for next 20 minutes. Approach to a child who is 14 months old with exanthematous fever. The other questions that can be asked are differential diagnosis of fever with rash, it could also be enumerate the causes of fever and rash in a certain age group, or it could be mention clinical features and investigation in an adolescent with fever and rash. All of them will have different answers. Let's just look at some of them. How do you approach the question? Hello? Yeah. How do you approach a question like when you're writing the first one? So you just give a brief introduction, or if there is a definition here, then you can mention it. And then you go on to each one of them. Let me give you an example. So better to treat this like a case presentation. And generally in an approach, unless specified, you are supposed to use a discussion only up to clinical diagnosis, and investigation and management are not required. But if there is, say, a child with bleeding, a child with bleeding comes to you who is 2-year-old, then you might want to write investigations at the end in order to come to a conclusion. Or a child with, or say you say a refractory anemia, then you may want to discuss investigations, not just stop at clinical diagnosis. Now, when you write this approach question, I would have written age, and you write age less than 1 year, fever with rash. So age less than 1 year would be so-and-so, and age 5 to 10 years can be so-and-so. If there is whatever is relevant out of this, you should try and remember. Okay, and same way you can go through rest of the things. When you're asking history, then talk about fever, talk about rash, talk about fever with rash, and talk about other associated history. Whenever we are discussing history of fever, we want to answer ODP like any other things. And for fever, if you have attended STEER program, they will tell you what are the 6 questions which are required for fever. Also, you always talk about onset, duration, and progress. So you talk about progress, you talk about what symptoms are associated, how many people with fever has this child been exposed to, and then further histories. Over a period of time, whether the pattern of fever has changed, whether what was the original pattern of fever, what are the factors responsible for changing the pattern of fever. When you take history of rash, you write about prodromal, whether there was any prodrome, when and where did the rash start, mean anatomically and chronologically. Has the rash progressed? Has the rash changed its appearance? Are there any other symptoms associated with rash? Each one, you will be giving an example of fever with rash. Okay. Or you can write relation of fever and rash. So this is a very specific situation. So now we are dealing with a child with fever with rash. You can either answer by saying fever and rash on day 1, rash appeared on day 2, day 3, day 4. Then rash appeared after day 4, rash appeared after day 7, and rash in a child with fever for more than 2 weeks and more than a month. All that will have different diagnosis. So that is one way of saying that. The other way of another point to add would be progression. So did the fever and what is the association of progression? So did fever and rash always come together? Then you say, okay, it's an evanescent rash and it's SOGI. If the rash appeared and the fever went away, then you say, okay, this is exanthem subitum. Rash appeared and fever continued, then you say it's more likely to be measles. Okay. Any other new symptoms, if they occurred, also you should be able to say. Always include the left-sided history when you are looking at approach and use appropriate things here. So now here in our case, fever with rash, history of travel and exposure would be more important. Family, past history and immunization are relatively less important. So you will ask whether there is any history of travel, whether any history of bites, whether any raw milk consumption, etc. When you are writing for approach, then you will write about, say, for example, different types of rash here. That will be more important. So whether this is a vesicular rash, whether this is maculopapular, whether this is bullous rash, whether the distribution wise, whether it is perianal and perineal and perianal as in Kawasaki, or whether it is limited to hand, foot and mouth as in hand, foot, mouth disease, or either the rash is malar rash of SLE, and so on and so forth. Whether the rash is affecting eyes and mucous membrane or it's not affecting them, whether there are any secondary changes in the form of infection, lichenification, pigmentation, etc. And lastly, you can write few common conditions to constellation of symptoms together. So say, for example, you write catarrh with cough, with maculopapular rash, with eye discharge, thinking in terms of measles, and features of Kawasaki and suggestive of Kawasaki, or features of SLE and suggestive of SLE. So there are various ways or multiple ways which you can put your approach answer. So when you're approaching writing for any approach answer, if you can think of an algorithm or flow chart. So for example, for fever with rash, what I thought was writing is first step is to rule out red flags. So what is the first red flag? Is the child sick? If the child is sick and has fever with rash, I would think of meningococcal, staphylococcal scalded syndrome, Kawasaki disease, COVID infection, Steven-Johnson, toxic epidermal necrosis, ecthyma or rickettsia. Okay. Then if I want to divide by morphology, I would say whether this is maculopapular, morbilliform, is it a vascular, or has there been an eschar developed? Lastly, distribution. So distribution, we already said palm and soles or groin, facial or lower limbs only affection. Like if you have only lower limb affection, you're thinking in terms of HSP. If you have facial affection, you're thinking more in terms of SLE. Whether the type of lesion, suppose there is a target lesion, then you're thinking in terms of drug-induced rash. And finally, associated features. So always look at joints, eyes, if there is any desquamation, whether there are any systemic affection, like pallor, liver, spleen, lymph node, etc. Okay. Whenever the question is asked on differential diagnosis of fever with rash, you must remember that answer should be age appropriate. You could divide it in the sense of number of on which day of fever did the rash appear, or which type it appeared, or it's the simplest thing for any differential diagnosis would be to remember, vindicate, or what is the different etiologies that you want to cover. And the same goes for enumerate also. So as I said, when it is differential diagnosis, you have to give some more explanation about pros and cons of each condition. Where it is enumerate, you just need to list like any other table which you see in Nelson. But again, not to list alphabetically, but have some kind of construct. or some kind of concept in that. So you can, if you're dividing etiology wise, remember to go through this list in your mind, vindicate or any other mnemonic that you think about. And you all know V is vascular, I is infective or inflammatory, and so on and so forth. You can also divide any causes system-wise, age-wise. That way you will not forget anything, and when you write the answer, the examiner will have some kind of a flow in which to give your answer. Now we have looked at how to write the paper, how to address the question, but the most important thing remains is the content. And unless your content is correct, nothing more can be done. So I would want all of you to now get your fingers on the chat box, and we'll try and make this interactive for next 20-25 minutes. Okay. So when you are looking at fever with rash, you are thinking of either infection, autoimmune, or drugs. What are the types of lesions we are thinking of? Maculopapular, vesicular, or papillonodular. You can also have a bullous lesion, a purpuric, or a gangrenous lesion. All of this can be possible with fever and rash combination. As I always like to say, first rule out danger signs. Okay, I want your answers. Rash on day 1, petechiae and purpuric rash, sick child. Please write your answers on the chat box. Okay. Yeah, meningococcemia. Anything else? Any differential diagnosis? Suppose there was no petechiae purpuric rash, but just a rash, just no information on that, just a rash on day 1. What things would you think of? Rash on day 1 with sick child. Okay. Correct. So important is that you have to remember that this is a sick child, correct? So this was the image. And most of you answered correctly by saying this is likely to be meningococcal infection. One more red flag, mucocutaneous rash plus bullous rash. Mucocutaneous lesions with bullous rash. But important is this is a sick child. Okay, pemphigus, all right. Pemphigus, okay. Anybody else? Sorry. Epidermolysis bullosa, okay.
Steven Johnson.
Steven Johnson, all right. Can it be erythema multiforme? Yes or no? Okay, so this is Steven Johnson. Important differentiating feature being mucous membrane affection. Erythema multiforme does not have skin and mucus, does not have mucous membrane involvement. Okay, starts with fever, mucosal involvement, eye involvement, dysuria and blistering of skin. Why it's important to remember, you can have a child coming only with dysuria and some eye involvement, and you would not correlate the two, or you would think in terms of Behçet's and other things. So these are erythema multiforme. If you can see, they are target-like lesions and no skin or mucus, no eye or mucous membrane affection. And you can see these lesions with a central darkening, and then there's a pallor, and then there is a ring it. And these are your target lesions. Okay. This is another one important area you should remember, and this is called as mycoplasma-induced rash and mucositis. So again, you have mucous membrane affection, you have polymorphous rash all over, and mycoplasma infection. And this is a known entity which has to be kept in mind, and you can discuss it in fever with rash. What about this one? Any answers? 7-year-old child with fever for 6 days, history of trekking tour, obviously pre-lockdown, with high fever for 5 days, headache, and now has come in hypotension.
Yes. Tushar, rickettsial.
Okay, very good. Scar and rickettsial. So it's a good idea for any child who comes with prolonged fever and acute illness to examine thoroughly, because this popliteal area could have easily, this eschar could have been easily missed if this was not really looked at. Okay, what is this? Same patient, little later. What is this? Can see the blackening of the toes. That is your avascular necrosis, which you can see in rickettsial fever. And what is this? Anybody? Okay, so this is your avascular necrosis of the pinna. And then when this heals, this can cause deformity and some amount of sloughing and disfiguration occurs. And so in rural Maharashtra, sometimes it is also known as Kankapia disease. Okay. Again, sick child, right? What is potentially serious here now? You have fever, malaise, macular erythematous rash, and skin tenderness. Skin tenderness. Exfoliation of skin perioral and periflexural. Any differentials? You can even speak if you don't want to write, that's fine. Okay, Kawasaki is one option.
Staphylococcus scalded skin.
Very nice. Why do you say that?
So skin tenderness and periorificial involvement.
Absolutely right. Okay. And what is that sign called?
Nikolsky's sign.
Nikolsky's sign. Okay. Because the line of cleavage, the level of cleavage is comparatively superficial. That's why you have this superficial skin peeling occurring here. And this is the periorificial coverage. So staphylococcal scalded skin syndrome. 9-month-old infant took measles containing vaccine, developed high fever and rash within, sorry for the spelling, within hours, was lethargic and rushed to the hospital and had this kind of a rash. Again, sick child. Any thoughts? Anaphylaxis, no, not really. Anaphylaxis within hours is unlikely. Anaphylaxis happens within minutes. Can happen in hours, but generally within minutes. What is the common complication of, not common, but known complication of measles containing via vaccine, especially if it is a multi-dose vial kept for some time after giving the first dose, after a couple of hours or more, use the given the second dose. TSS, correct.
Septicemia.
No, TSS, Dr. Sonali has written the correct answer. Toxic shock syndrome. And if you remember, some places in West Bengal and I think couple of UP or Orissa, I don't remember. They had multiple children getting affected after giving this. What happens is in measles, once diluted, becomes a potential culture ground for staph, and so they can multiply. And if it's not kept under good condition, used after a long period, then can end up with toxic shock syndrome. Okay, and this is another one. What is this? These are all fever with rash. Okay, just in case you are wondering where we are just showing you some images so that this will have you will have an idea about what fever with rash can be, and it's just not limited to measles and rubella and stuff like that, which also will be showing. So these are necrotizing fasciitis, and these have anaerobic as well as staphylococcal, both cover is required. Okay, 2-year-old girl, fever 1 month, 1 week, fever for 1 week, toxic look, shock, generalized black coin-shaped rashes. What is this? Okay. This is ecthyma gangrenosum. And what is the organism implicated in this? It's gram-negative bacilli. Okay. And it's very can be very toxic and very severe. So you need to take care of that. Pseudomonas is the commonly implicated organism. This I don't need anything to say about, right? You will give me the diagnosis on this one. Fever with rash, day 5.
Kawasaki.
Kawasaki. Okay. Excellent. What about this one? So if you can't see it clearly, I'll tell you what it looks like. This looks like hyperemic toes, which are red. It's maculopapular rash. And this is some vesicular rash and urticarial rash. One common infection which can present with all these dermatological manifestations. So one common fever with present can lead to this, all 4 of them. So again, fever with rash, right? So don't forget that. Commonest infection. Now at least some answers. Which is the commonest infection? Commonest infection in the world. Which is the commonest infection in the world? It's COVID-19, correct? So it's COVID toes, or what is called as pseudo chilblains, meaning pseudo frostbites, where there is erythema with vesicles or pustules, and you can have vesicular eruptions, you can have maculopapular eruptions, you can have urticaria, and you can have skin necrotic areas also. The commonest is the maculopapular eruptions, as well as sometimes chickenpox-like infection. Now we come to this bread and butter standard fever with rash timeline, okay? Unfortunately, the viruses don't read Nelson and they don't follow Nelson, so they don't always do this, but this gives you some idea to write an answer. Always remember, first day fever and rash is never viral. It'll be drug rash, it'll be allergic rash, it can be meningococcal, can be a severe gram-negative sepsis, but not viral. So don't relax if you see rash and fever on day 1. It may happen that fever was there for a couple of days and parents have not noticed. That is a different story. Second day onwards, it could be a scarlet fever, where I'll show you. Third day, exanthem subitum, then measles, mumps, rubella. Day 5 and onwards can be dengue or Kawasaki, and beyond 7 days, you think about various other conditions like lepto, EBV, etc. But if you are in second week, lesser chance of infection, only odd infections like EBV, brucella, etc. or subacute bacterial endocarditis. And beyond that time, think of non-infective conditions like SLE, SOGI, or a petechial purpuric rash of leukemia. All right. Come on, last 10 minutes.
Measles.
Fast. Measles. Okay, describe the lesions for me quickly.
Morbilliform lesions and complex spots.
Okay,
Mm-hmm.
this one.
Mumps.
Sorry?
Mm-hmm.
No, not mumps.
No.
No. You can see that thick sandpapery rash, and you can see lymph nodes along with that, sore throat, petechial hemorrhage on the palate. So this is scarlet.
Coxsackie virus.
Scarlet fever.
Scarlet.
Coxsackie also doesn't give rise to lymph nodes
Lymph
very easily.
node.
Yeah, this gives. Okay. Somehow my. Just give me a moment. What about this one? What about this one? You can see this 105 fever, 103 fever, fever gone and rash appeared. Happy child.
Roseola infant.
Exanthum subitum, right? What about this one? Edema and erythema on both hands and feet with associated petechiae purpurae, oral lesions. You can see the screen clearly, right?
Yes, sir.
Okay. So like a slap cheek. The idea of showing an Indian face is that on our skin, it looks very different than what you see in the textbook images. Okay. But it's important to know that they can have oral erosions, vesicles, lip edema, and hand edema and edema of both hands and feet. So which other condition of fever with rash gives rise to edema of both hands and feet? Kawasaki. Very good. Okay, this is what we discussed just now. Okay, this is a rash of EBV. If you can see here, this white membrane, which you can see. And then there are other features also which are mentioned. What about this one? Maculopapular rash, dermographism or flushed skin, and rash when the child was recovering.
Dengue.
Yeah, dengue fever, correct. So initially, different stages, you have different rash that you know, but in exam, you can mention like this when you're writing an answer for this one, right? What about this one? Anybody? Patchy diffuse maculopapular rash with on healing left hyperpigmentation. That is the clue. And I'll give you a clue that this is an arbo infection, arbovirus infection. Anybody? Chikungunya. Okay. Very good. Sachi has already written. Sorry, it says some lag. I am not able to see it clearly. So there are two things. One is you can see it in young adults. You see this hyperpigmentation, and in newborn or in young infants also you see hyperpigmentation. So you need to be clear about that. Sometimes they show you newborn images in your skin or young infant images. Fever with rash. Just if I show you this much, what do you think? Monsoon illness.
Leptospirosis.
Yes, very right. Correct. What about this? So it looks like a target lesion, but this child has come from US. It's an NRI, Lyme disease. Very good. Just a good idea to know that. Let's look at some vesicular or papillonodular rashes with fever. So the commonest being varicella. The differentiating points of varicella, you know, it's usually centripetal. It has multiple stages of vesicle seen, and there can be associated scratch marks. Herpes simplex are again, they are in clusters, vesicular, small, and along the mucocutaneous junction, or in certain specific areas that are more common, like lips or genitals or eyes. And then you have herpes zoster, which have a dermatomal distribution. You can have SJS or SSSS as we saw, and very commonly we see HFMD, hand, foot, mouth disease, where you have fever and rash, which is there on face, palm, soles, elbow, knees, buttocks. And then lastly, another last two, these two, no, HFMD and scabies go amongst the papillonodular. It means the lesions are much thicker rather than vesicular. So what is this? Chickenpox, correct? And they're umbilicated, of course, that is very important. This one?
So hand, foot, mouth.
Correct. Herpes simplex, perioral, herpes zoster. What is this? Fever with this mark. This is not relevant, okay? Fever may or may not be there, but the child was brought to the hospital with this. So you have to look out for non-accidental injuries. I don't think we should spend time on that. Just included that as part of this differential diagnosis. And then this particular area of shin and elbow, you can get these kind of red patches and thickened nodular areas called as erythema nodosum. What is this? Osler node, genuine lesions, splinter hemorrhages, and tender pulp of fingers, which you see in subacute endocarditis, correct? SBE. What about this one? Okay. So you see malar rash, you see oral ulcers, and you can see the skin lesions and joint swellings. What about this one? The child had edema of the hand and feet and had fever, was irritable, under 2 years of age, with some lesions primarily starting from lower limb. So this is the younger version of HSP. The HSP happens in bigger children and the pattern is not like this, but this is acute hemorrhagic edema of childhood, which is considered as a HSP in below 2 years of age. They can present only with this kind of rash, which looks very scary and otherwise is self-limiting. This is your standard HSP that you see, and this is how it looks. Usually limited to lower limbs and up to buttocks, but can be there in upper limbs and sometimes rarely 10 to 15% even on the face. So that does not rule out if somebody has a rash on the face along with lower limbs and upper limbs. Okay. So finally, from fever with rash, the take-home message is that rash is more of a symptom than sign, and associated symptoms are extremely important. Always remember first day rash with fever is not viral, and any child with fever with rash, if he's sick, it's a red flag. Okay. When there is rash with short history of fever, it's more likely to be infectious. But if there is prolonged fever, it's more likely to be either unusual infection, or if it is the PUO category, it's more likely to be autoimmune or malignancy. Okay, thank you. I'll stop sharing. If there are any questions, I'll be happy to answer. Otherwise, it's 5 o'clock and it's time to stop. Thank you, Dr. Rajesh, Aditi, and IIP Mumbai for this opportunity. If there are no questions, you can feel free to leave. Yeah, thank you.
Tushar, you did a wonderful job.
Thank you, sir.
Okay, it was very, very enjoying and very, very informative. So nice.
Thank you, sir.
Thank you, sir.
Sir, I have one doubt.
Please.
Does chikungunya present with fever or rash in children, or like fever with generalized body ache or joint pain? Like what's the usual present?
You are very right. What I am telling you is not to suspect chikungunya in a child who has fever with rash, but other way around is to know that if a child has hyperpigmentation subsequently, or if the child has fever and rash and joint pain, it can still be chikungunya and not necessarily SLE or other conditions.
Okay.
We are writing a theory answer, so the difference between a case presentation and theory answer is, in theory you are using a wide angle lens, so you're trying to cover more stuff. But if you are answering in the exam, you are using a tele lens or a microscope, where you are giving very focused answer, only restricted to the given patient in front of you.
Okay, got it. Thank you, sir.
Thank you. Thank you.